Hello, I'm Dr. Malcolm Monroe, clinical professor in the Department of Obstetrics and Gynecology at UCLA and Director of Gynecologic Services at Kaiser Permanente Los Angeles Medical Center.
Hello, I am Dr. Jin-Hee Kim, Assistant Professor of Obstetrics and Gynecology at Columbia University Medical Center. In this segment, we will discuss the Palm-Coin subclassification system for leiomyomas.
FIGO AUB System 2, the Palm-Coin system, includes a subclassification system for leiomyomas designed to assist or guide clinicians, trainees, surgeons, and investigators. The system can help with clinical evaluation, identification of appropriate therapeutic options, and, for investigators, aid in evaluating the role of leiomyomas in the pathogenesis of both AUB and other symptoms. The system comprises 3 levels. The first level simply defines the presence or absence of leiomyomas, generally using simple transvaginal or transabdominal ultrasound. The second level categorizes submucous leiomyomas versus those tumors that are not in contact with the endometrium. This usually requires the use of contrast transvaginal ultrasound or hysteroscopy. The third level provides more granularity. The submucous leiomyomas are classified as being type 0, 1, or 2 based upon the Wamsteker definition from the early 1990s that is based upon the proportion of the mean diameter of the leiomyoma that is in the myometrium. Type 3 leiomyomas were added by FIGO and describe those that are intramural but which are in contact with the endometrium without any focal distortion of the endometrial cavity. So type 0 myomas are intracavitary with a pedicle or stalk that is less than 10% of the mean diameter of the tumor. If less than 50% of the mean diameter is intramural, it is classified as being type 1. However, if the leiomyoma focally distorts the endometrial cavity and greater than or equal to 50% of the diameter is intramural, it is classified as being type 2. Type 4 leiomyomas are intramural, with some amount of myometrium existing between the inner margin and the endometrium and between the outer margin and the uterine serosa. Type 5 leiomyomas are in contact with the uterine serosa but have at least 50% of the largest diameter in the myometrium, while type 6 tumors have less than 50% of the diameter located in the myometrium. The type 7 tumors are the subserous analogs to type 0, in that they are attached to the uterus with a pedicle that is less than or equal to 10% of their mean diameter. Type 8 leiomyomas really comprise all others, including cervical and the so-called parasitic leiomyomas that have no direct connection to the uterus.
An important group introduced by FIGO is the hybrid leiomyoma. These fibroids are in contact with both the endometrium and the uterine serosa. This relationship is especially important for the surgeon contemplating hysteroscopic removal or other intrauterine surgical therapies that will be introduced over the next few years. Hysteroscopic removal of the entire leiomyoma is not really possible with, for example, type 2 to 5 leiomyomas, and the risk of damaging surrounding structures would be significant. The identification of hybrid leiomyomas can be achieved with ultrasound, but there are frequent limitations. In many, if not most instances, MRI is probably more accurate and reliable. It is important to remember the rationale for this subclassification system, particularly with respect to submucous leiomyomas. For AUB and likely infertility and recurrent pregnancy loss, the relevant myomas are likely those that are in contact with the endometrium, because of the potential global effect on local function. The studies shown here demonstrate that relevant endometrial molecular changes are evident when leiomyomas are in contact with the endometrium. However, when the leiomyomas are present but not submucous, the molecular characteristics are similar to those in the normal uterus.